I hope you have had a great day in the workshops. It sure seemed like you did, because there's been a lot of on Twitter, some exciting tweets from inside the workshops. There were also tweets with attention to the fact that Uppsala University will invest in a new antibiotic center. Somebody posted at 14:41, and I quote, "And now the tricky part begins. How do we make it happen?" So unless this problem was solved in 19 minutes, there will still be work to do for tomorrow. A little later this afternoon, we'll have representatives from the workshop on stage and hear about what happened there and the results, some bullet points maybe, what must be done in what order and by whom in different fields. But first, we have 3 keynote speakers here in a panel, and the title is Gain Political Commitment and Reach Implementations. We have 3 national examples. And the persons here from the right is Martha Gjansalutrot. She's director of the pharmaceutical services in Ghana. And Hetty van Beers, who is here, is director of the Netherlands Veterinary Medicines Authority. And in the middle, Suit from the Thai Ministry of Health. So, Martha, I would invite you to start.
Thank you very much. Good afternoon, ladies and gentlemen. I will begin by sharing some of the experiences we had in gaining political commitments, reaching implementation. I'm sure you all have a fair idea where I'm coming from, West Africa, and in Ghana, population of over 26 million, and our per capita and all the issues are in there. What has been the key challenge, access versus access? This is what we have. You see medicines being sold as if they are articles of commerce. And we know we have some structures in the private sector, but the private sector I always describe as a failed state because you can get anything from there. There are actions of freelance, informal sector, medicines vendors, there are a lot. The access in context of access, we have irrational prescribing by health professionals and the use of antibiotics, the quality of the antibiotics, the socio-cultural, economic, and supply storage issues. These are key issues. Like I said, you see medicines being sold as if they are articles of commerce, and you can see them being sold in the marketplace. You can really appreciate where I'm coming from. While somebody is selling oil, the medications are also in a tray. What are the known causes of death for children under 5? If you look at the list I have, obviously, key issues of HIV/AIDS, measles, pneumonia, diarrhea, malaria, these are all treatable diseases, but our children are dying from them. And then we have the neonatal causes. So if you take the 27% out of 8, the rest are antibiotic-related. We have just conducted a demographic and health survey in Ghana, and these are how the children are faring. We have improved a bit in terms of our child survival from 50 in 1998 to just about 41. And of course, under 5 mortality dropped from 80 to 60. I would like to introduce you to a project that happened in Ghana that changed the face of antimicrobial issues, the ADMA project. It was done by the university in collaboration with Danida and they turn out a lot of data on quality of antimicrobials, various levels of resistance, and when you visit their website, you will see a lot of these issues. There was a dissemination in March regarding these. We have identified barriers to access to medicines, and like you can see, 40% is on quality, 20% is on access, whether geographic or financial. Of course, affordability is also 40%. And the quality, we know that medicines like substandards, spurious, falsely labeled, falsified, and counterfeits are also circulating on markets. And our storage of medicines is quite poor. This data came from our office out of over 10 years of measuring antibiotic use at health facility. In fact, this is the only indicator that we have on the rational use of medicines program. And we began by 56.3%, and it continued until we started the Ghana AMR program and consistently dropping, especially the contact with antibiotic by health professionals with patients. How has these barriers been addressed? By forming a medicine selection committee of experts. They continually update the essential medicines list and the National Standard Treatment Guidelines, and of course, the National Health Insurance Medicines List. And of course, the National Health Insurance provides financial or solves the financial barrier situation where people can have access to medicines in terms of antibiotics. And this one defines at what level you can get the antibiotics. The process to gain political commitment began by some of the studies that we have conducted. One is an in-depth assessment of the pharmaceutical sector. We have looked at the situation analysis, identified barriers to access. We have looked at stakeholder analysis, who is involved in antibiotic use or misuse. And we identified all the sectors that must be on board: Ministry of Trade, Ministry of Health, local government for sanitation, Ministry of Finance and Development Planning. And the last group we identified has been Foreign Affairs. And I tell you that when we identified this group, things began to change for better for us. Because most often at the Foreign Affairs, they don't really pay attention to some of these issues until you begin to engage them, let them know the importance of it. I don't work in Geneva, but I am in constant contact with the first secretary, and anything on AMR, he sends it, and I respond in quick time. And so when it comes to the WHO issues on AMR, Ghana finds itself very well represented. Civil society organizations and media had been people we identified, and of course, the development partners in health. We continued the engagement with these groups, with subcommittees at all levels, and in 2014, for instance, the aid memoir, which is an agreement between the Ministry of Health and its partners, including civil society, as to what agreements we have for the year and things to be done. And one of the agreements was to come out with a policy framework by December 2014, which we did. The universities had been engaged, especially with the ADMA project. Some of us found ourselves as one of their steering committees. And so we tried to guide them as to the type of things, type of research that will help us. And that is why currently they have put economic burden of antimicrobial resistance as an issue that one student is doing a PhD in. We have drafted a comprehensive cabinet memo to engage the presidency through the sector minister. We have costed our implementation plan that is waiting for, that will be taken through the consideration stage. And of course, the approved document will be sent out to the ministry and the agencies for implementation. But what is interesting here is that because everybody has been involved, although the policy has not been approved, all issues are already being taken on board. And of course, monitoring and evaluation will give feedback to the policy process. In conclusion, ladies and gentlemen, the process of engaging different players, especially politicians, is in a multi-stakeholder approach is very strategic. There is need to build a lot of networks among health professionals, networks among the universities. You know, the universities have different areas of work, especially those in research. We needed to engage the social health researchers, the other researchers like the microbiologists and all that. So we tried to engage them and build effective networks with them. And I must say that data speaks, and speaks very loudly. And so once we got those information, we shared with the ministry, we shared with stakeholders, we shared with most of our stakeholders, and it was speaking, and that is why we have come this far. I must say that political commitment to access can be achieved if politicians and key stakeholders are engaged right from the beginning. And I think that is what we have done. We thank you for listening to us. Just our website, you can go there and see the things we're doing. Thank you very much. And there are people you may know, wherever you are sitting, who are on this, who has really been supportive of the work we did in Ghana. Thank you very much. I acknowledge my staff for all the great work.
So do you have questions or comment on Martha? Just wave a hand and a microphone will come to you. What do you think when you listen to Martha?
Yeah, listen to Martha. I'm very impressed.
Yeah.
Because all the things they've done in Ghana, and I'm coming from the Netherlands, and it's easier for us to arrange all these things, and we have the infrastructure digital and in a lively way. So I'm very impressed what you have done and what you have reached so far. So.
Yeah, it seems that she has had good access to politicians too.
Yeah. That's very good.
Yeah.
Do
you have the same experience?
Yeah. I think that we had a minister who was interested in what we were doing. And because we have the information, the data from the universities as to what was happening in the country, she gave a lot of go-ahead. And what was interesting about it is that just when we finished the World Health Assembly the last year, which we organized a side event with Netherlands, and immediately we went back, she was changed. You know, the ministry they took her to, she went to Ministry of Fisheries. And you know, when she was going, she called me and said, Martha, now we are going to do the antimicrobial resistance more because of aquaculture. And so these are how the networks began. And of course, I engage a lot with the parliamentarians because most of my work has to get through Parliament. The drug policy, the selection of medicines and all that. So that placed me in a very unique position to engage with them. And of course, the Ministry of Health engagement processes in terms of the sector dialogue. We meet on different platforms and we discuss. And luckily for us, the current chairman of the Parliamentary Select Committee on Health was a previous Minister of Health.
Oh, that's good.
So I think things came together to support the work.
Tell me, was this an exceptional way of policy making in Ghana, or did you have sort of a model from another policy area that you could relate to?
When I showed the last slide, I showed a lot of people who have helped us along the way. Otto was one of them. I came here 2010 for the Uppsala Summit on antimicrobial resistance, and one question I got up and asked, why are we continuing to talk? Why can't we take action? Yeah. And I'm sure he took notice of that. And the rest is the history you are seeing. Yeah,
I meant in the context of Ghana, when you make policies in other areas, is this an exceptional way of working?
Yes, it is, because it takes the element of multi-stakeholder approach. The reason being that it's not about health alone, it's about Ministry of Agric, Ministry of Finance, and Ministry of Foreign Affairs.
Yeah.
So this is how we approach it. And I think that having learned other lessons through multi-stakeholder way of working, it has helped us to build this platform. And I think also that we have also got very interested partners, like the civil society organizations. They are very, very supportive of the work that we're doing. The universities, nevertheless, they do their research and it remains in the universities. And this is an area that they did their research, and immediately we brought it into to give us evidence for policy decision making. And I think this is one area that I am particularly grateful to the universities.
Yeah, you mentioned that Danida had been in on the Admon project.
Yeah.
So Danida is the Danish foreign aid agency.
Yeah.
Do you think that's a good idea that more countries should sort of work, when they work with health policies as foreign aid, that they would concentrate on AMR assistance?
I think that it depends on the context. We thought we needed some information on that. And before we approached Danida, we already have something in our plate, that this is what the universities wanted to do. And they also found out that who else in the ministry is working around that. And so they contacted me. And that is how it came. So we have had long-standing series of meetings before the training of the scientists began.
Yeah.
And so...
Someone in the audience? Because I can't really see you all. Suit, do you want to comment on what Martha is describing?
Your question again, please.
What do you think about what Martha has been telling us?
Well, one conclusion I can conclude is this issue is very context specific.
Yeah.
What worked in Ghana may not work in Ethiopia or Thailand. So this is something that you need to keep in mind. Some principle you can use, but some practice, it is very context specific.
Het, did you want to add something?
Yeah, I do fully agree with what Stuart is saying, because it depends on the country, it depends on the culture, and what's possible and what's not possible.
Yeah. So now the prospects are good. The work is going on. It's going to be durable. What's happening in Ghana?
Yeah, I think that what is left is the implementation. And like I said, all this dovetail into the Global Action Plan. And before the Global Action Plan could come, which of course I was part of the engagement, we already have put in place along the same lines of the Global Action Plan. And so our policy is ready. It's already available on our website, but we wanted to ensure that the presidency gives the final approval, then we can outdoor it as we do in Ghana. And so the next steps will be implementation of the policy document. And that brings me to the point that the Africa Group kept raising at the assembly, that we needed to begin to look at the financing of the Global Action Plan. Otherwise, it remains a plan and not an implementable plan.
Yeah. Hetty, do you want to continue?
Yes, please, but I think I'd like to stand up, otherwise I
Yeah.
can't see my slides.
So now we turn to antibiotics in livestock in the high-income country of the Netherlands.
Okay, thanks for the invitation. I'm happy to explain what we did in the Netherlands and how we came to do that, because there was some special things what happens to us. I would like to emphasize that I will talk now about the gain of political commitment, and tomorrow one of my colleagues will tell you more details about our approach in the antibiotics in animal production. First of all, I have to tell you that we are a very small country with a lot of animals in it. And to make this clear, we have just 17 million people, and then more than 1 million dairy cows, veal calves, pigs, and a lot of chicken. And we're all living together and close together and have huge discussion about huge stalls for these animals and the effect of these animals on the environment. I have to explain to you that we have a very special situation in the Netherlands 5 years ago, because when you look at the amount of antibiotics used in humans, we were the best country in Europe, And at the same time, we have some data from the EMA in London, and they showed that in 2008 we were the highest users of antibiotics in farm animals. So when these data were revealed, the discussion started in the Netherlands about using antibiotics and about antimicrobial resistance. So far, we had microbiologists who were warning of using a lot of antibiotics without looking at the consequences of antimicrobial resistance, but it was not part of the policy in the Netherlands. And then I think between 2004 and 2010, we had 6 things what happened, and I'd like to show you what happened in the Netherlands. First of all, you'll have to know that the Netherlands is one of these countries with a search and destroy policy for MRSA. So when of people in a hospital is positive for MRSA, they would like to eradicate the MRSA in the hospital. And what happened then, there was a daughter of a farmer, of a pig farmer in the Netherlands, who would have to be surgeon for heart disease, went to a hospital, and then they found another MRSA, and it was a non-typable MRSA according to the human microbiologist. And this MRSA came from pigs, because it was found on pig farms in the Netherlands, it was found on farmers in the Netherlands, it was found from their relatives of farmers in the Netherlands. And then microbiologists started to complain that they would like to deal with MRSA coming from abroad, but they do have problems with dealing with MRSA coming from the Netherlands. So something has to be done. And 2 years later, we had an outbreak of Q fever. We knew, I'm a veterinarian, Q fever was just as to do with people working in slaughterhouses. That were the stories from Australia. But we have a huge outbreak of Q fever in the Netherlands. 25 people died because of Q fever. And it was because there were a lot of goats in the Netherlands, in the southern part of the Netherlands. And they had aborted, and then this bacteria came out of this, the small goats and all things, and then people got contaminated. We were very happy that these farmers didn't use any antibiotics to treat these animals because they know it didn't work. But the discussion of having a lot of animals together and the impact of having these animals together on the environment and the people living there, it was the second time that we have discussion in 2 years. And then in 2010, there was a conference in the Netherlands about ESBLs. ESBLs, as you know, are enzymes which could break down the antibiotics used against gram-negative bacteria. And then the microbiologist told us that the lady has died in the Netherlands because she was not treatable anymore. When you have these things together, and you have a country like the Netherlands, and we are a little hype sensitive in the Netherlands. So when something happens in the Netherlands, it's huge, and it's a huge problem, not only for the people of the government, but everywhere in the government and everywhere on the street. And at the same time, you have signs that the antimicrobial use in the Netherlands is the highest in Europe. And looking at having a lot of animals together and the impact of these animals on the environment, and of the impact of having a lot of animals together on their welfare, and you have a political party, it's called Party of the Animals, then I think I can explain to you that we don't have to influence the policy anymore because there are a lot of things happening at the same time. And that was the reason that they say, okay, let's look at the use of antibiotics in the human health, but let's discuss the use of antibiotics for the farm animals. And at the same time, we have to realize when you have a lot of animals, we don't eat them ourselves. So we're exporting a lot of meat, and we're exporting a lot of milk. So there were it was not only a problem for the farmers that they have a license to produce, but when we still do have income coming from selling these products abroad. So it was a license to produce not only for the farmers, but as well for the government. And that was the moment the policy makers said, okay, it has to be done something. And would like to share with you today what were the risk factors, the key factors why we were successful. And the first of all, and this mentioned more than once today, was awareness, 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 awareness. I was a vet in the past, a practitioner in the past, and I think in the last 20 years, when you're a Dutch practitioner and you go to visit a farm and you're talking about antibiotics, you were always talking about cheaper antibiotics with a broader spectrum, easier to administer, and they were very cheap. And now what happens between 2010 and now, everything what has to do with antibiotics has changed. And the vets told their farmers that what has changed and what is the impact what has changed. And that started with being aware that we're using antibiotics, the risk of using antibiotics. The Dutch people talk a lot, and talk together about how to deal with all these problems. And it started then with a covenant between the livestock sectors and our Minister of Agriculture. It was in 2008, 2009. And they say, what can we do together to solve the problem? So they make new rules, and it was just private rules, not public rules, but private rules to improve the health at farms and to start with the transparency of the uses at each farm. Because everybody realized that when you sell a lot of antibiotics and you're looking for the one who's using the most, then it's very important that you know how many antibiotics are used in each sector. So we started with analyzing the data of the Dutch farmers, and nowadays we have the data of all the Dutch farmers in our system. And after analyzing them, we set some benchmark values so that each farmer knows I'm in the middle group, I'm the highest user, I'm the lowest user. And the one who are the highest user, they have to take all new things to improve their health status and to lower the use of antibiotics use at this farm. We have these benchmark values for farmers, and we have them for vets as well, because we know there are some difference in the prescription behavior from vets in the Netherlands. And at the same time, the government said we have to set some goals that you know what you have to do. And there were goals set for 20% reduction in 2011 and a 50% reduction in 2013. When you listen to me and say, okay, they do all things together, yes, this is just an overview of all the things that has been done in the last 5 years, and that you can see that we are not allowed, we're not allowed to use antibiotics in food. I'm not talking about antimicrobial growth promoters, but it was possible in the Netherlands that when you're a practitioner, that you phone to the feeding company and say, okay, I would like to ask you to add these antibiotics to the feed, for example, weaning plickets. That's forbidden, and it's private, it's not in our laws. It was forbidden by our government to use the antibiotics in a preventive way, so it's not allowed anymore. There are a lot of conditions for administering these antibiotics by farmers themselves. In the Netherlands, it was possible when you're a vet, you go to a farm and to said, okay, I think you need these antibiotics in case these calves got diarrhea, and you can administer them yourself. And then our minister said that's not possible anymore because you're using too much, and now they are allowed to under certain circumstances. And these rules were set by the government. They checked our Food and Consumer Products Safety Authority, checked the correct use of antibiotics, and they found a lot of mistakes because they didn't do it the way it was written down in the leaflet. So they checked it, and then they said, okay, there should be penalties for people, for vets and for farmers who use it in the wrong way. And we said new, and that's carried out by the Dutch Veterinarian Association, new formularies. Formularies in the Netherlands have to do with first, second, and third class antibiotics, so which antibiotic is in which class, and after looking at the ISBL and for example, the beta-lactamases are now in the second class and not in the first class anymore. And we have guidelines for vets, and these are developed by the Veterinary Association as well. So now the vets in the Netherlands know what they have to do when they see some kinds of illnesses. Oh, now, then about the results, and I show first the first figure. That was the increase of antibiotics in the Netherlands from 1999 till 2007, 2008. And then in 2009, when our Minister of Agriculture told us that there was some reduced the use of antibiotics, then you can see at this figure, these are the results till 2014, and there was a decrease of almost 60% in the use of antibiotics. Is that very important? Yeah, we are very happy, we're very proud of the farmers and the vets who did this, but is that the most important thing? No, it's not the most important thing, because the most important thing is talking about reduction in resistance and not just reduction in use of antibiotics. And what we're doing nowadays, or our expert panel is doing this, is that we like to compare the data of the decrease in the use of antibiotics for the several sectors. These are veal calves, chicken, sow and piglets and feathering pigs, and they are now modeling the relation between the decrease in use of antibiotics and the decrease in microbial resistance, antimicrobial resistance, and they will, at the end of the year, report if there is any relation and what kind of relations. And another question, how many antibiotics do you have to reduce to have an acceptance level of resistance? And that's a very difficult question. So I think I come to my last sheet, and my last sheet, what were the success factors in the Netherlands to reduce use of antibiotics in farm animals? it was awareness, 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 awareness. And what helped everybody to act and to do something, it has to do with the fact that the microbiologists, the human doctors, the political parties, and the media as well paid a lot of attention to it, so that all the farmers and all the vets know in the Netherlands that they have to do something to the use of antibiotics. And that was my presentation.
Wow. Well, having an animals party.
Yeah, having an animals party, yeah. So
I
special.
heard there are 2 seats in the parliament.
2 seats in parliament, and they're growing.
Yeah.
Yeah.
So what are their demands now that they have sort of achieved this goal?
Oh, but they want to go further and further and further, further. Every time when this topic is discussed in the Dutch parliament,
Yeah.
they say, okay, nice what you've done so far, but we think 80 or 90% is be better than just 50%. So there's continuing, and they use this topic to discuss the way we capture our animals. That's important in the Netherlands. They say they like to have more welfare and more freedom for animals and not putting them together in huge stalls.
What are the sanctions?
The sanctions. I think I'll explain tomorrow, but I'll explain to
Do
you
you go to
shortly.
prison, or do you have a
In another-
fine,
yeah.
or
No, I have.
nobody breaks the
no.
law, perhaps?
The first initiative was a private initiative. So what happened in the Netherlands when you are a farmer or a vet in our called red zone, then you got a message from your own quality system, and you have to make a new plan of a health plan to improve the health of the farm and all the things you can do to improve the health status, to prevent diseases, and to use less antibiotics. And in case you are for 3 consecutive times in this red zone, then the name, address of the farmer and of his vet are sent to our Food and Consumer Safety Authority, and they go and visit this farm. The levels you may use are not in our law, but these people can check everything on the farm, what's in the law, and there's no farmer in the Netherlands and no practitioner who would like to have these people on the farm because they can find everything what's wrong on the farm. And I think all farms do things, but not always according to the rules. So that's and then they can start giving penalties.
Yeah. What do you say to that, Martha?
I think that it's actually worth noting, because in our action plan we needed to do guidelines for veterinary practice, and we never had it, so it is something that we will take home. But I must also say that it is just not on our side, it's just not the political stuff. The health professionals also contributed to it, because our teaching hospital was closed down in 2012 because of infection from, spread of MRSA. So those are the issues that brought about the fact that we needed to have a policy on the antimicrobial resistance.
Yeah. Suit, do you have a comment?
You mentioned you have 2 seats in the parliament.
No, not we. The part of the animals have 2 seats.
I know. The group that moved, they have 2 seats.
2 seats, yeah.
And expanding.
Yeah.
This is the key. If you want to influence politics, move into it. If you stay away from it, how can you influence it?
That's true.
Well, we had 2 seats in the parliament. That was, yeah.
150.
Well, anybody want to say something? Yes, there's a microphone for you, just behind.
Thank you very much. Hello. Yeah. Just a few questions to the Netherlands story, which I think is very interesting, and it's a very good job that you have done. Does it have any implications for the animal welfare that you reduce the level of use of antibiotic? Because that's the reason why, at least it's argued, that you use antibiotic. That's because of animal welfare. So does that imply anything for the animal welfare?
Yeah.
And have you seen a reduction in the level of MRSA in the Netherlands? That was one of the arguments that you said in the beginning. That was a reason for the reduction. Can you see a reduction, for example, in the pig farming area?
Did you have one of the seats for the animals party? No. Hattie.
Okay, thank you. We'll try to give a short comment on that. First question is about welfare. Everywhere I go and I tell what we have done in the Netherlands, the first question is, and what are the effects on welfare? So it's everybody's very involved in what happened to them. As far as we know now, we've seen no negative effects on welfare. But when you look at our colleagues from Denmark, they have made the same process, gone through the same process 10 years ago. They saw a short decrease in welfare, but after that they saw an improvement in health status, an improvement in welfare. And I think it has to do with the fact that there has to be something changed between the ears, what we say, of the farmer and the veterinary together, and then they have to look for better ways of management of the farms, and then when they are well equipped to do it a better way, then it's better for the health of the animals and better for the welfare as well. But there are these rumors in the Netherlands talking about welfare and not treating animals because they are afraid that they are in our red zone. And we have a special board in the Netherlands giving advices to our Minister of Agriculture. And this board starts in the kind of research work for if the welfare in the Netherlands is decreasing or not. So we'll be waiting for the details and for the figures if it's true or not. That was the first question. And the other one about production of MRSA. We don't have the details of this research work, but there was research work done in the Netherlands, and they showed a relation between reduction in the use of antibiotics and reduction in the prevalence of MRSA in the farmers and in the animals as well. So there was a positive association.
Oh, yeah. I don't know who was first. You start.
Thank you. My question is not necessarily maybe for the panel, but it could be for anyone in the audience. The Netherlands story triggered something that I remembered reading in one of the daily papers at home, where a concern was raised about genetically modified organisms. So the story was like there was a concern of some crops that were being modified, and these crops would secrete some antibiotics. So the concern in the paper was that this could interfere with the nature and can promote antimicrobial resistance. I realize that we've been focusing on antibiotic use in animal husbandry, but there's kind of silence on this, if it's a real thing or it was just a story, I don't know. I never really followed up on that matter, but I've just remembered after listening to you.
We'll take this next question directly, and then we can answer together.
Yeah, my question's rather complementary to the first one. What was the effect on farmer output and incomes?
Yeah.
Patty?
Maybe it's easier to refer first to the last question and then come back to
Yeah.
the first question, if you don't mind. Looking at the products of the performance of the animals in general, they see sometimes increase in mortality. That should happen, but we don't know if this increase in mortality it was in veal cows and was related to outbreaks of salmonella, if it was because of this specific type of salmonella, or it has to do with the fact that farmers don't use these antibiotics in a preventive way anymore. So we keep an eye on what's happening while you're reducing the use of antibiotics. Maybe it's good to add that this question is what are the consequences for the vets as well, because the vets were delivering these antibiotics in the past and did earn some money with selling these antibiotics. And when you look in the Dutch practitioners, nowadays they do more to prevent diseases, so it's more in a preventive way. They use more vaccines than they did years before. So I think in general the income of the vet will be comparable with the years before. And I think the income of the farmers in general has decreased a little because they have to pay the vet, but as long as they have to pay the vets, and it's almost 4% of all the costs as a farmer have, it is just a small effect on the finance of the farmer.
So Martha, and then
Yeah.
we'll go on to the Thailand case.
Yes, I just wanted to find out whether this reduction of antibiotic use in animals, whether it is only for local consumption, or whether what about those that are exported to the developing countries, whether it's the same standards applies, because I know sometimes some products are meant for local production and others for export. I just wanted to...
Yeah. I cannot agree with that because I think that the farmer in the Netherlands does not know at that moment that these animals are going abroad or staying in the Netherlands themselves. So as far as I know, they're completely the same. Yeah.
Thank you. Suit?
First off,
A short one.
So, as Suet has mentioned, it's often context specific. So, what has the great successes that you've shown in the Netherlands, may be more challenging in low-income countries, particularly in low-income country farmers. What advice would you give to low and middle-income countries, and what is the Netherlands doing, and other groups, as far as you know, doing to collaborate to try and improve this issue in low and middle-income countries? Thanks.
Do you have to comment on that?
I think it was for Hetty, right?
Yeah. I think thanks, but it's a difficult question. And I think when I can just tell you why we were successful, what has to do with the fact that we were creating awareness. That was the most important thing, because in the past everybody thought that antibiotics are just there to solve the problem that day treating these animals, not realizing that when you're using antibiotics there are some side effects we were discussing about today. And I think it's very important for everybody in the world to realize that when you use antibiotics, it's always a trigger for bacteria to develop something to combat it. And I think that's the most important thing, that they know why we are very prudent in prescription of antibiotics. I think that's the most important thing. And I think in other things, I think it's very difficult to say what will help in other countries, because it depends on the situation in the country and the culture in the country as well. When I compare what we are doing in the Netherlands and compare it, for example, to Belgium or to Germany, it's different. And then we're living in such a small area in this globe. So it has to do with the way people like to solve a problem. And it's very important that everybody feels more or less comfortable with the way you solve the problem.
Thank you, Hetty. Now, Suit, it's your turn to describe to us the successful introduction of antibiotic smart use program in Thailand.
well, thank you, Cecilia. As a policy advocate, a major policy advocate, or policy lobbyist for many years, what I want to share with you is broader issue on how you can influence policy and make them successful, using as much as possible stories that link to antibiotics. What we want to contact policymaker and politician is not just to influence them to decide the policy for us, but also to influence them not to decide on bad policy. These are equally important. Don't just move on getting some policy. You must move on get rid of bad policy as well, because there are people who propose bad policy. We usually have we learn from many years of experience, not only me, but our group of policy elites in Thailand. 5 important points when you want to move policy into good implementation and contact policymaker. First, you must address their interest, not your interest. If AMR is not their interest, you must find something to attack their interest, and then gradually move on to get your interest. What are the interests of the politician? They want a success track record. They want good image. No matter how bad politicians they are, they want good image. No matter how corrupt they are, they want to be clean. They want to look clean, right? and they want votes. So if you work with them for some good policy and they get the vote, they'll go with you. For example, when we move on the universal health coverage policy, that was a time of election, near election. And one new party came with the idea that they are going to propose attractive policy. We immediately went to them. Do you want to buy this policy? They grabbed it immediately and sell it. They know how to sell it. We don't know how to sell it, but they know how to sell it. And won the landslide election. When they succeed, immediately they came to us. Here, help me to implement it. If I am not successful, I will lose my vote. And you have to help them to implement it successfully and gain their trust. Gain their trust and long-term recognition. Trust is very important. Trust equal reliability times credibility divided by self-interest. So if your self-interest is the lowest, you are the best public policy advocate. If you have very high self-interest, you are for private sector. Second point that we learned. We need multiple and right connection. We work in group. Some of our members connect to this group of politicians very well, but bad to the other group. Some of our group members good to this political group, bad to the other. So we know when to use who to connect. And also, not only the politician, but their advisor, anyone who can influence them. You can find more time with the advisors. And you need to connect to sometimes global, influential people. We just moved on in the past few months to propose a new tobacco bill, which will increase the age of tobacco sale from 18 to 20 years, and many other things. Of course, huge opposition from the tobacco industry, and they mobilize retailers, mobilize farmers. We have to mobilize our people, but at the same time, we asked the DG of WHO, Margaret, can you write a letter to our Prime Minister? We got that. And her letter is very influential to the final decision of the Prime Minister to pass this bill from the cabinet, in the cabinet. And you should understand that we are having a military government. Cabinet decision is more or less like a parliamentary decision. Okay? So we need to have right and multiple connection. You need to be well prepared. Opportunities prefer only prepared mind. If the opportunity comes, you have nothing in hand, you lose the opportunity. So we do many health policy, health system research, prepare ourselves ready. For example, when the human papillomavirus vaccine came in, we know that one day our policymaker will make decision on that. We immediately carried out technology assessment to assess its cost effectiveness, budget impact, delivery system. And soon the opportunity comes. We submit it to them. We should not make the decision now. Price still high. Wait. While the other lobbyists lobby for inclusion in the benefit package of universal health coverage. Of course, we have to work with the women's group because they will kill you when you say that HPV is not necessary. It's not yet approved. They don't like it. But if you work with them from the beginning, they understand the cost effectiveness, the impact, whatever. They will not be moved to the other side. So be well prepared with evidence, policy brief, and create public awareness. Policy advocates need to learn the skill of elevator test. You all know elevator test?
The elevator pitch? Is that
Elevator test.
Yeah.
Well, if you want to meet with the minister, he's on the 10th floor, and very difficult to get his time. The best is to wait in front of the elevator in the morning before when he come in and want to go to his office. Immediately you get into the same elevator and you have the time to talk to him and get his interest on the policy you want to sell. And then you buy more time, maybe 30 minutes more or 1 hour more. This is the skill. The fourth one, you need social movement and engagement in politics and policy decision. That's why I'm so happy to see that you move into politics. 2 seats. When we move on the universal health coverage, we mobilized 50,000 signatures of the Thai national, Thai resident, to propose the bill to the parliament. That is constitutional, under our constitution. 20,000 people can propose a bill to the parliament. That bill, once the people propose the bill, the government has to propose a parallel bill, and the opposition has to propose another parallel bill to take the seat in the special commission to consider the bill. And this representative of these 50,000 people get 5 influential seats in the special commission to consider the detail of the bill. And because of that, they get 5 influential seats in the Universal Health Coverage Board until today. Not the same group, they take turn, but representing civil society and community. So you need social movement and engagement. Last tactic, you involve policymaker and politician in certain important forum that they feel that they become important and they get engaged. For example, at the last Health Assembly, we know that AMR is still not high in our minister agenda. So we put in his speech to the Health Assembly 1-2 paragraph on AMR. That's got his buy-in. Something he already commit through his speech. But written by us. This is a tactic you can use everywhere, even with your boss. Whenever someone asks you to draft a speech for them, that's your golden time to insert your policy. Second, Honorable Minister Gabriel convened the breakfast meeting. We convinced him to go. We know that there'll be a call to action. Now, my minister become a member of the Global Alliance of Champions on AMR. He become the champion, commit to be a champion. Right? And we even work with other countries to convene a side meeting and put him as a speaker. And we wrote his speech, 3 minutes on AMR. This is how you engage them in important forum, build up their image. And when they go back home, they'll not forget AMR. Okay? But in the implementation, that is more tactful. We usually use the principle of 5 E, A, B, C, D, E, 5 E. Not in series, sometimes in parallel, sometimes in series, and in combination. The first E, education, create awareness that you mentioned. But we found that most of the time education is effective in at most 20 to 25% of the case, and more effective in educated people than in low education. Second E, engineer, tech research and technology development. When we want to reduce the use of antimicrobial in common cold, which always have sore throat, always come with sore throat, we invent a small spotlight and mirror that easily for the doctor and nurses, even nurses, to diagnose whether this throat is red enough for antimicrobial or just not red, it's viral. Mostly are not red, it's viral. This helps them to make good decisions. Third E is the economic, like financial incentive. If you prescribe less antibiotic, you get more money. If you prescribe more, you get less money. This we are using in Thailand, in the Universal Health Coverage Scheme. Fourth E, enforcement. Reclassification of antibiotics. Over the counter, prescription only. Very restricted use. And prohibit the use of antibiotic as growth stimulator in animal feed. And last E, empowerment. AMI is a very complex social issue. You need to empower everyone to collectively solve the problem.
I don't know what to say. This was the most fascinating lesson of political science that I've heard in a long while. It's also a bit like watching House of Cards somehow. And it makes you think about, this modern day Machiavelli telling Lorenzo in Magnifico, who is asking, how do I get the love of the people? And he answers, well, you introduce an antibiotic smart use program before an election.
I don't think that will catch the interest of the public.
Thank you so much. Wonderful of all of you. Thank you.
Well spoken.